Thank you very much. I hope everybody's doing well. I know you've had some very busy weeks learning about nodal contouring and postoperative oral cavity contouring. And so we're going to switch topics today to talk about contouring cranial nerves. Next, what I want to talk about is just what is perineural invasion? And really what perineural invasion is when you see tumor cells crawling within the nerve sheath. That's the most common phenomenon of perineural invasion. But you can also sometimes have tumor actually within the nerve, and you can have intraneural spread. I think the difficult thing for all of us about perineural invasion is that it can be contiguous or it can have skip lesions. It can be radiographically visible. It cannot. In fact, I'm going to talk about how the earliest signs of perineural invasion are unfortunately all clinical. It takes many years before you can see this on an MRI. It can progress in the anterograde direction. It can progress in the retrograde direction. I think some of the most common histologies that we know cause perineural invasion, tend to be adenoid cystic carcinomas, so salivary gland tumors, cutaneous squamous cell carcinomas, especially those are very high risk. And then one particular type of basal cell carcinoma, which is infiltrating or sclerosing basal cell carcinoma. So these are three of the most common histologies where we're asked to, chase nerves. Certainly in mucosal malignancies, nasopharynx, very locally advanced nasopharynx oftentimes present with cranial nerve palsies, as well as nasal cavity and paranasal sinuses. You can see perineural invasion along any of the nerves, but the most common ones I think we all see in clinical practice are going to be the second and third branch of the trigeminal nerve, so the lower 2/3 of the face, and facial nerves as well, so cranial nerve 7. Even in an age of exquisite technology where we have lots of imaging available to us, I do think that this is one area where your clinical exam is extremely important because oftentimes you will detect which nerves are involved before you can see on a scan. And as I said, it usually takes on the order of 9 months to 3 years before a patient with clinical symptoms will have any radiographic findings on imaging. This is just a picture showing you how perineural invasion spreads. So you can see the perineurium around the nerve, and you can see that it's really right along the perineurium where you see tumor. And then sometimes you can have tumor within the endoneurium, so you can have intraneural spread. This is a histology slide showing you that. So as I alluded, these are the most common malignancies that cause perineural invasion. So really the biggest problem primarily in skin cancers and salivary gland tumors, but certainly in some mucosal malignancies like oral cavity, nasal cavity, paranasal sinuses, and nasopharynx, this is a big problem. I wanted to share some data about skin cancers and what locations are, notorious for possible perineural spread. And you can see that it really can happen anywhere in the skin, but the most common being the skin right over your cheek. And you can imagine it's because of the access to the infraorbital fissure right here underneath the orbit on your cheek, where skin cancers can go right through the path of cranial nerve V2. Other things that you can see is that locally advanced cancers, particularly T4 tumors, have a predilection for cranial nerve spread. So as we have locally advanced cancer, something for us to think about. Nodal disease in itself does not predict perineural invasion. It really is the location of the primary tumor and the extent of the primary tumor. There are different levels of perineural invasion that we see in our clinical practice. The most common is incidental, or something that you find on a pathology report. So these are patients who have no clinical symptoms, who have no radiographic findings. It's just you looking at the path report, whether it's a Mohs report or whether it's a report from a salivary gland surgery where you see that perineural invasion was found. Clinical P&I oftentimes, as I mentioned, precedes radiographic findings. And the most common scenario for me to see this in is somebody with a remote history of skin cancer who's had their skin cancer treatment, whether it's surgery or radiation, and then comes to you with new onset of numbness on the face or a new onset of facial nerve palsy. They see their primary care doctor, or they see their dermatologist or head and neck surgeon. They order scans like an MRI or a PET scan, and there's really nothing visible on there. And so these are the patients that are often misdiagnosed. They're oftentimes diagnosed with herpetic neuralgia, They're diagnosed with Bell's palsy. And so it oftentimes takes many years before you get a pathologic diagnosis in these patients. And then finally, radiographic PNI. So these are patients who generally already have those clinical findings, and now you can see something on imaging. This is some data from University of Florida showing you local control and cause-specific survival based on the type of perineural invasion you find. So what you can see is that when patients have incidental PNI, they can actually do very, very well, especially if you're offering them postoperative radiation to the resection bed. And even generous coverage of that resection bed will treat a lot of the PNI. When somebody comes in with clinical PNI, now you can see that local control drops significantly because now you have to make sure that you're appropriately treating nerve paths. And then finally, radiographic PNI, you can see that this is where, so once somebody has findings on imaging, I always tell these patients, your disease is treatable, but generally not curable unless it's confined to limited area of involvement on imaging. This is again just showing you local control, and you can see why it is most important for us to make the right decisions when patients have incidental PNI. So this is when you're actually meeting the patient after surgery. This is the time to make the decision whether you're going to treat these nerve paths or not. Because if we can offer appropriate treatment here, you're very likely to cure them. This is a meta-analysis looking at skin cancers and again, looking at the risk of local recurrence and disease-specific death. So this is, again, for incidental PNI. So for skin cancers, we're just on a path report. You notice that there's perineural invasion. And you can see that in this meta-analysis, local regional control, or local recurrence here is on the order of 17%. So local control is on the order of 83%. So I know our Mohs surgeon love to say, if I do Mohs, your cure rate is 97 to 99%. That is actually not true for patients that have PNI. This is now looking at the same cohort of patients in this meta-analysis when patients present with clinical perineural invasion. And you can see that now local recurrence is a much bigger problem. 37% of these patients will have a local recurrence. And you can see that disease-specific death is on the order of about a third of patients. So this is what I mean about patients with perineural invasion and who can you cure and who can you not cure. So we talk about this zone 1, zone 2, and zone 3. And I know this slide is a busy slide, but you can think about this very simply. Zone 1 is going from the skin to the cranial nerve foramen, sorry. So you can see for V1, that's going from the skin to the superior orbital fissure. V2, it's going from the skin to foramen rotundum. For V3, it's going from skin to foramen ovale. And then for cranial nerve 7, it's going from skin to, or from the parotid gland generally to the stylomastoid foramen. Zone 1 patients, if you have a patient that presents with perineural invasion in zone 1, these patients are operable. And generally, the standard of care for these patients will be surgery followed by coming to see you for postoperative radiation. And these are very curable. Next is zone 2. So this is now going from zone 1 intracranially. So for trigeminal nerve, that's going to the Gasserian ganglion cistern. And for facial nerve, it is going through the mastoid segment into the, so this is the nerve as it goes through the mastoid segment and ends up in the internal auditory canal. These patients, I think, are operable with significant skill. So you really need an expert head and neck surgeon who is comfortable operating in this setting. But there can be significant morbidity from surgery. So the reality is, only about a third of these patients are going to get surgery in the clinical setting. Most of these patients, the surgeons are going to pass on operating. And then finally, zone 3 is when that disease goes from intracranially into the brainstem. So you can see anytime disease is going into the brainstem, it is essentially incurable and inoperable, treatable in the modern era, but certainly some patients where you may give them good palliation, but you're not going to cure them. I will tell you the one caveat, particularly for skin cancers now, is the use of immunotherapy. So even when I look at patients that we've treated, 5, 7 years ago before the routine use of immunotherapy versus now, where if somebody presents with any PNI, we add immunotherapy, we're seeing that these patients are living a lot longer. So I think that with effective radiation and immunotherapy to help control microscopic disease, we're in a much better place today than we were 5, 6 years ago. So you should feel more optimistic than you would have even a couple of years ago, especially if your patient is able to get immunotherapy. This is again just showing you that data. So patients with perineural invasion and in terms of their outcomes. So you can see with all comers, overall survival is about 64%, and then disease-specific survival is about 75%. And then you can see local regional control is on the order of 60%. And this is with effective treatment. So this is when patients are getting surgery and definitely postoperative radiation or definitive radiation. And when these patients recur, you can see that majority of these patients are going to recur within the first 5 years after diagnosis. Zone 1, as I mentioned, is salvageable. So even if you've radiated them, oftentimes these patients can get surgery if they've not had prior surgery. If you've not radiated them, you can add radiation pretty effectively to curative doses. And generally, in their experience, this is again the Florida experience, zone 2 and 3 recurrences after prior therapy were generally fatal. This is now showing you just perineural invasion by zones and their disease-specific survival. So again, just highlighting again, zone 1, very, very curable. Zone 2, curing about half the patients. Zone 3, disease-specific survival, you can see, is on the order of 15%. One of the other things we'll talk about as we go through each of the nerves is the involvement of one nerve versus tumors jumping from one nerve to another nerve. This should come as no surprise to any of us. If multiple nerves are involved, patients don't do as well. Their disease-specific survival is going to be much lower. So how do you treat perineural invasion? So for patients with microscopic disease or incidental disease, this is generally, as I mentioned, something that you have on a path report. The pathologist is not naming the nerve. They'll usually say focal perineural invasion. And these patients, I think, just need postoperative radiation to the resection bed. So for a skin cancer patient, this is basically treating with a very generous margin with electrons, making sure that you're covering the scar, making sure that you have hopefully a preoperative picture so you know exactly where the skin lesion was, and really anatomically putting in margins of 2 to 3 centimeters around the cancer or the scar for those patients.
Dr. Parag, I have a question for you.
Sure.
So this is not in the chat, it's from me. But are we talking here, or does it depend on the nerve caliber or the length and depth of the perineural invasion, or here is the overall perineural invasion? Because sometimes we get that nerve caliber extent to define what we're going to do. So I wanted to ask you this.
Correct. So I think when you look at things like NCCN, you'll see the size of the nerve. So nerve caliber over, 0.1 millimeter or 1 millimeter at the cutoff that you use. I think
Yes.
that those are helpful, but by no means should you not treat somebody who doesn't meet the nerve caliber. I think that if you see perineural invasion on a pathology report, because especially I think that it is very difficult, especially in a Mohs specimen, for a pathologist or a dermatologist, especially, as you know, majority of the Mohs specimens are read by the dermatologist. It's very difficult for them to actually give you the nerve caliber or the size of the nerve, on that path report. So I think for us, really, especially if the decision is just to add postoperative radiation to the resection bed with electrons, really, this should be an easy decision for us. Really, don't perseverate about nerve caliber. Don't perseverate about named nerve. Just add radiation, particularly for, just squamous cell carcinomas and basal carcinomas. I think that you should do that.
Awesome.
Yeah, you're welcome. In these patients, when they just have incidental PNI, are there situations where you should actually now trace the nerve? Yes, and this you'll see that I'm going to talk about this over and over again. So if you forget, don't worry. Obviously, for skin cancers, the two things I look at: if you have a sclerosing or infiltrating basal cell carcinoma, this is pathognomonic. for PNI. So even if the pathology report doesn't mention of any PNI, if you see the word sclerosing or infiltrating, you have to assume that that is PNI. And of all the basal cell patients that we see, I think these are the highest risk patients where they will fail along the nerves. So I think it is very reasonable to electively treat at least to zone 1 for these patients. Certainly for a squamous cell carcinoma, if you're seeing extensive microscopic PNI, and or if the patient is immunosuppressed, so if a patient is an organ transplant patient, or the patient has underlying CLL or myelodysplastic syndrome, we know that some of these conditions really increase the risk of local recurrence and regional recurrence. So you can consider treating the nerve path electively in those patients. And then for non-skin cancer patients, again, as I mentioned, adenoid cystic carcinomas, so those salivary gland tumors, nasopharynx cancers, nasal cavity and paranasal sinus patients, if you have a pathology specimen that shows PNI, please make sure that you treat nerves in those patients. For patients with clinical PNI, so these are patients where they have a prior history of cancer, generally a skin cancer. You do imaging, there's nothing on imaging, but they come to you, you should always make the decision to treat. And this is generally really, really hard for us because you have nothing on a scan and you have no biopsy. All you're going on is that this patient has had a previous skin cancer in the anatomic distribution of where that perineural invasion symptoms are. So somebody who has a prior history of a skin cancer on the forehead and now is presenting with V1 symptoms, you should make the call to treat. Or somebody's had a prior cheek cancer and now they have V2 perineural symptoms, you should make the decision to treat. And for these patients, you're at least going to cover zone 1. And if they have radiographic PNI, you're going to actually go all the way to zone 3. You're generally going to go all the way to the brainstem to cover for these patients. Again, just that same information that I mentioned earlier for non-melanoma skin cancers, when do I think of tracing nerves? As I talked about infiltrating and sclerosing basal cell carcinomas. And then other things that I take into account really are these risk factors, especially in squamous cell carcinomas: immunosuppression, recurrent disease, extensive microscopic PNI in your pathology specimen, and then a very locally advanced skin cancer. So, in San Diego, I see, unfortunately, I always call them T10 skin cancers. They are so advanced, they're eroding into the bone. Those are patients where you should just electively treat with those nerve paths in those patients. What dose? There's really no consensus. I think this is where the principles of head and neck cancer radiation come into play. If I'm just going to treat the resection bed for somebody with either microscopic or incidental PNI, I'm going to follow just the very standard skin cancer doses that I use. So the first thing I look at is, where is this skin cancer? How big an area am I going to treat? How cosmetically sensitive is this area? And based on that, I decide whether I'm going to do a 6-week course or a 4-week course or a 3-week course. And then I pick the fractionation based on that. So this is really just how you're going to treat skin cancers postoperatively. In San Diego, and I'm sure where you are, a lot of skin cancers you see are in patients who are well into their 70s, 80s, and 90s. And so these patients, to make them come 6 weeks is really hard. So you will see that I do a lot of hypofractionation in my practice for these older patients where I'm not nearly as concerned about cosmesis and just want to get them done as quickly as possible. Now, if you're going to treat nerve pathways, this is where really the principles of head and neck radiation come in. So for patients that have extracranial gross disease, you're going to radiation doses of 66 to 70 gray like you would for any mucosal head and neck cancer. For any microscopic nerve paths that you're chasing extracranially, so from skin to the skull base, radiation doses of 54 to 60 gray. Intracranially, as you can see, we run into trouble. It's hard to give 70 gray inside the brain, inside the skull. And so for these patients, generally I go on to the order of 60 grays, and I'm usually limited by, things like optic nerves, brainstem, and temporal lobes of the brain. Now, if somebody has extensive perineural invasion in the orbit, where the eye is not working, in fact, I have to contour one of these cases right after this talk today, where that the globe is completely not working. The patient has V1, 3, 4, 6 involved. The eyelid is shut. They're never going to be able to use that eye. I am more comfortable going to a higher dose with the consent of the patient and telling them that it's very likely that they will need an orbital exenteration for symptom management years down the line.
Parag,
And then yes.
a question about how do you manage the temporal lobe probability of necrosis when we go to higher doses in that size?
Great question. So again, we all treat GBMs in the brain, and you treat these to 60 gray all the time, and you probably take a hotspot of 107, 110%. So generally, I'm pretty comfortable. I'll usually say that D.0, 0.03 cc's, to be at 66 gray. That's usually the constraint I'll give the dosimetrist. So a D max of around 66 gray. I won't exceed that, but I feel pretty comfortable going to 66 gray, really based on the data from gliomas in these patients. And then for microscopic disease, where you're just doing elective nerve coverage, 50 to 54 gray is pretty adequate. And then, as I mentioned, for the vast majority of skin cancer patients, at least here, we try to give them immunotherapy concurrently and adjuvantly for a year to 2 years. And so I actually feel really good about not going to very high doses for microscopic disease, because I know that, they're getting the 1-2 punch between radiation and immunotherapy for these patients. This is just a paradigm that you can take a look. This is an algorithm of when you should do perineural chasing. I just added this so that you can look at it at your convenience. What nerves do we think about? Again, as I mentioned, the talk is going to focus on just the trigeminal nerve and the facial nerve. And then here you can see, depending on where the primary of the tumor is located, these are the nerves that can be involved for those patients. So just something for you to have. This is a really nice table just showing you how these nerve paths travel. And we're going to look at this in pictures, but I just wanted you to have something that so you can reference to, but we'll look at lots of pictures just in a minute. This is just showing you, as we all know, the first branch of the trigeminal nerve innervates the upper 2/3 of the face, the middle branch, the maxillary branch, the middle third, and then the mandibular branch, the lower third of the face. So let's talk about these nerves. So here is cranial nerve 1. For me, this is the hardest nerve to treat, I'll be honest, because you have to go inside the orbit. This is showing you a skin cancer patient with a skin cancer you can see right on the forehead. And there are 2 foramina right on the skull. There's the supraorbital foramina and the supratrochlear foramina, and these are the 2 nerves that go through there. And they sit really right next to each other. And you can see that these are the areas where the supraorbital nerve innervates, and this is the area where the supratrochlear nerve innervates. And oftentimes there is a lot of overlap here. This is just radiographically showing you the supraorbital fissure right here. This is where that nerve is going in. So going right from the forehead going in. And now this is showing you an axial image. This is that superior orbital fissure. So if you have a skin cancer right here, that tumor is going to travel along this way and end up in the superior orbital fissure. If you have, say, a lateral canthus tumor, skin cancer here, that tumor is going to travel right along the lateral rectus muscle here and come out into the superior orbital fissure. So you can see no matter where you are, if you're chasing cranial nerve 1, you have to go inside the orbit. So now you have to really think about organs here. So you're worried about the optic nerve, you're worried about the retina, you're worried about the globe itself, you're worried about the cornea, and you're worried about the lens. The lens, as you know, is the least of our issues. You can treat the tumor and tell the patients that they are going to get a cataract and they're going to need cataract surgery.
Dr. Parag, for hypofractionation, would you use another set of constraints? At my center, we really use the HANCA, but I was wondering, if you're using hypofractionation, which constraints will you use when you have this case that you have the optic structures nearby?
Great question. So I will say that generally for most patients, if I'm chasing the nerves, I don't use hypofractionation. But rarely it comes up, that 90-year-olds that have really bad perineural invasion, where I have to, give them some palliation. And I'll tell those patients that I'm not, that the intent of my radiation is just for palliation. And you're exactly right. I'll use the Dahanka constraints, and I'll usually treat that. If I'm treating somebody over a 15 fraction regimen to the skin, giving them 50 gray, I'll take the nerve pathway intracranially to say, anywhere from 35 to 40 gray, and use some Dahanka constraints. So that's a great question. But for the vast majority of patients, I will do standard fractionation here. So I'll treat them over 6 weeks.
Awesome, thank you.
So from the superior orbital fissure, the nerve traverses through the cavernous sinus. And this is where you see we run into trouble. This is the patient that I'm going to contour later today, who really the PNI started in V1, but unfortunately ultimately went into the cavernous sinus and now is affecting cranial nerves 3, 4, 6, and V2. So this is the exact case I'm going to contour today. So you can see how a single nerve involvement untreated over time gets to a patient where now they have multiple nerves involved. So this is just showing you again on an MRI. So this is a patient with perineural invasion. You can see disease is now going through the superior orbital fissure into the cavernous sinus and actually going into Meckel's cave. This is pretty obvious on imaging. I will tell you that I know that when you're treating these patients, these findings are not nearly obvious on imaging. So if you're looking at a CT, even just the widening, of the bony aspect of the cavernous sinus should be a clue that something is wrong. One of the key things I do my trainings all the time is everything, especially for about PNI, when you're looking at imaging, whether it's a CT, an MRI, or a PET scan, it's about symmetry, symmetry, symmetry. So compare to the contralateral side, and you will see subtle changes, expansion of the bony canal, mild enhancement that you see on an MRI should really make you suspicious that there's perineural invasion here. And so again, this is now showing you cavernous sinus. Meckel's cave is going to be here. This is a really nice coronal picture of an MRI. You can see cavernous sinus medially, and you can see Meckel's cave laterally. When disease goes into the Meckel's cave, sometimes you'll see that the disease will then, from the Meckel's cave, actually start spreading along the dura, right along here. So be mindful of that when you're looking at these pictures and looking at this imaging. And always look at the MRI on the coronal space when you're contouring. It's very helpful to ensure that you've covered both the cavernous sinus and Meckel's cave in these patients. This is again showing you on CT, and you can see how hard it is to see anything on CT, particularly on bone imaging. And then here you can see here on MR. So these are the patients where I will say, if you have a PNI case, MRI is really, really helpful, even if there's nothing visible on MRI, just to allow you to contour, because it gives you a really nice roadmap to make sure that you're covering the cavernous sinus, make sure that you're covering the Meckel's cave. And if you're going any further, that you're covering the segment of the trigeminal nerve all the way to the dorsal root ganglion, all the way up to the brainstem. So this is where the MRI can become very helpful for you. So this is one such case, just showing. So this is a patient with a skin cancer with a perineural recurrence. You can see some bolus on here. You can see that you have the supraorbital foramen, the supratrochlear foramen. So both of those nerves, you can see they're right next to each other. And you can see you contour in the foramina, and oftentimes, I just contour in, my CTV around that area. This is just showing you as another patient where you have this, where you're contouring this. This is the foramina up here. And then I'm going to contour. So you can see here's the optic nerve. You're really going to cover a lot of that retrobulbar fat space, as you can see. So again, showing you that nerve path right here. And this is just showing you the musculature of the orbit, kind of just showing you anatomically where it's going to be. And what you will see is that typically as you're contouring these, you're going to contour, just entrance and exit, and then you're going to cover all of that area. So, don't spend a lot of time, contouring inside the orbit, just contour the foramina. So if you can contour the superior orbital fissure, and you can contour the entrance of where this is coming, you're literally just going to cover all of that retrobulbar fat space, because the tumors can really crawl right along there. And so you can see, and the optic nerve is going to be right in the field for you. And then once you get to the superior orbital fissure, now you're going to contour posteriorly going into the cavernous sinus. And again, you can see why an MRI is so helpful for you to be able to do that. But if you don't have an MRI, just go along the bone windows and just contour right lateral to the sella, and you'll be adequately covering that area here. This is again one of my patients. You can see the patient actually has radiographic PNI. You can see all this thickening is actually gross disease, and so you can see I've contoured in the fissure, contoured in the tumor, contoured a nice CTV coming along here. So you can see this is my CTV, and then you can see the CTV is now extending inside the orbit. I'm swinging out here to the superior orbital fissure, and from the superior orbital fissure, then I'm swinging out to cover the cavernous sinus. And I wanted to just show you on CT because reality is many a times you don't have the luxury of having MRIs. And if you don't, you can really well contour this on a CT for these patients. And this is just a sagittal and coronal view for you, so you can get an idea of what this looks like going all the way back to the cavernous sinus for this patient.
Maybe, Parag, you can make a comment on the need of the use of contrast enhancement in the head and neck setting.
Yeah, that's a great question. So I will say that if I have an MRI, I just get a non-contrast CT. But if I don't have an MRI, I will get a contrast CT. I think that is where contrast really helps, especially if you have, disease that you can actually visibly see with contrast in these patients, inside the orbit. If you're getting an MRI, the one other thing I should mention, if you have the luxury of getting any MRI you want, for V1, you really want an MRI orbit with fat saturation sequences, in addition to a regular MRI brain that you're getting, so that you can really delineate these tumors really well. This is probably one of the original papers in the Red Journal by Iris Gluck that just shows you different cranial nerves and the different pathways. Unfortunately, in this paper, there's only one picture for each of the cranial nerves, but you can see this is a V1 patient, and you can see that they've covered the entire bony orbit and then going all the way into the cavernous sinus. And we'll talk about these V2, V3, and cranial nerve 7 in a few minutes. So I wanted to ask a question. You've seen some pictures of contouring cranial nerve 1. And so now you're going to contour this for a patient for a high-risk non-melanoma skin cancer, and you decide that you're going to trace this to the cavernous sinus to 50 gray. As you look at these pictures, what do you expect the Dmax to be to that optic nerve?
Okay, so let's launch the simple question. I expected Dmax, yeah. Sorry. Listo. Entonces todos deberían ver en sus pantallas la respuesta. But some people is answering on the chat, Dr. Parag. So lots of D answer.
Very good. You're listening.
Lots of Ds.
That's exactly right. So I just wanted to make the point, you can't spare the optic nerve, right?
Oh.
So this is exactly the thing that I wanted to make sure that you got. Very good. All right, everybody's listening. That's great. So the next is the maxillary branch. So this is the middle third of the face going to the infraorbital foramen. That's where these tumors are going to go through. This, I will say, is probably the easiest one to contour. So because it's very easy anatomy, and I'll walk you through the anatomy in just a minute. But these are going to go through the inferior orbital fissure into the pterygopalatine fossa. We are all very comfortable covering this because we treat lots of head and neck cancer patients. You're going to go to foramen rotundum, cavernous sinus, and end in Meckel's cave. So this is just an example of a patient with a skin cancer where this is something that you should be considering. And here is a sagittal, a coronal view, of basically where that inferior orbital fissure is. So you can see it's literally right underneath the orbit. And what I want you to take away from here is that so look at the right side, look at the left side. All you see here is widening of that foramen. And this in itself should be a clue to you that something is going on here compared to the opposite side. This is now, again, showing you some images of this on the axial slice. So these are very easy for us to see because, we're all very used to contouring this, head and neck cases here. So here you can see the nose, the nasal cavity, the maxillary sinus, and here is that foramina right here. Okay, so right along here is where that foramina is going to be. And then as you're chasing this foramina, this is on the opposite side, you're typically going to go from this foramina, you're going to go right along the lateral wall of the maxillary sinus. So it's going to be going right along here. And then you're going to end up right here in the pterygopalatine fossa. Here is foramen rotundum. And then this is the Vidian canal going in. So this is, again, as I said, this is one of the easiest ones for us to contour because we're so used to contouring in the nasal cavity and the maxillary sinuses. Just giving you some idea of how that goes. And the nice thing about here is that, treating here to, doses that we want to treat this, this cancer to is relatively easy because there are not very many other organs at risk that you're worried about in here. It's just musculature, soft tissue, fat, and bone. So going to dose, if you need to treat gross disease along this path to 70 gray, it really is not a big issue for you to be able to do that. This is now showing you going from the pterygopalatine fossa into the cavernous sinus. And then this is going into Meckel's cave. So again, you get that same idea of where it ends up. And this is an example of a patient where you can see this same kind of concept, somebody where you're going to treat this starting from the skin. So you can see here's some contours. This is the cheek coming from the malar cheek. If I were to treat this, I would add bolus here, but you can see this going through the fissure. So this is the initial contours. And then now, as I mentioned, going laterally along the lateral wall of that sinus, and then ending up here in the pterygopalatine fossa, right here. And then you're going to come into the Vidian canal. This is an unusual example. So this is somebody with a tumor of the hard palate. We don't see very many of these. And so here you can actually, give me 1 second. I'm going to try to move this poll. I'm going to stop sharing for just 1 second. Give me 1 second. Okay, can you see this now? Perfect. So
Yes.
these are patients with palate tumors, and what you see, these are hard to trace. So this is somebody with a hard palate salivary gland tumor, and you want to trace the path of V2. And so this is unlike going from the skin, going along the lateral wall of the maxillary sinus. This is actually these tumors spreading through the greater and lesser palatine nerves. And so you can see for these patients, you're really going to cover all of that hard palate. And from here, it's going to crawl up into the Vidian canal and then go into the cavernous sinus and Meckel's cave. So this is a rare instance of how these contours go. This is one of my patients. So this is a patient with adenoid cystic carcinoma. This is some preoperative imaging to show you the preoperative MRI, and then this is the postoperative CT. And I've blended them so you can kind of get an idea between the preoperative MRI and the postoperative CT. So this patient did have surgery for this adenoid cystic carcinoma, and you can see what this path looks like. In this patient actually had nodal involvement, unfortunately. So you can see that's why I'm going out so laterally to actually cover the nodal basin. But just getting you an idea of, just for this patient of what these contours look like. So you can see going intracranially for this patient along through the pterygopalatine fossa, through the Vidian canal, through the cavernous sinus in these patients. And I wanted to show you, postoperative settings don't look nearly as pristine as the intact settings. The patients had surgery, so a lot of that bony landmarks are gone as you're tracing this for the patient. And then this is going up higher. So again, just kind of showing you now going up at the level of the nasal cavity. And so you can see going into, through the skull base, going into the cavernous sinus here. And you can see this is kind of what this looks like on a coronal setting for this patient. V3, so this is the lower third of the face. The classic skin cancer patient is going to be somebody who has a submental lesion, so a skin cancer here. And this is generally going to go through the mental foramina, going along the mandible, into the mandibular foramen, and then going, medial to the lateral pterygoid, and ultimately entering through foramen ovale. These are challenging to treat for a whole nother set of reasons, and I will show you that in a minute. So here is somebody with a lip cancer, and you can see some contours here. So it's contouring the lip, going through the submental foramen. Unfortunately, the biggest challenge in these patients is that these nerves traverse right through the mandible. So this is the challenge for treating V3. So here is the mandibular foramen, and you can see as you're contouring this, your CTV really needs to generously include all of that mandible. As we all know, we go out of our way to spare mandible all the time for most of our head and neck patients. And here you have to really, you can't spare the mandible. And you can see here's the mandibular notch. Here you can see on the left side, and that's where the mandibular foramen and the mandibular nerve is going to traverse through. So you're going to contour that notch right here. And then as that nerve goes up higher, it's going to be going, through medial to the lateral pterygoid. So now you're in the area of the nasopharynx, and you have to make sure that you contour that pterygoid musculature and the peripharyngeal fat for these patients. And this is what I mean. So here you can see here are the pterygoid plates, and it's going to be medial to the lateral pterygoid. It's going to go right along in here through this area. And one of the things that you can see and sometimes in these patients is that if you have gross PNI, it'll actually invade into the pterygoid musculature and then actually sometimes spread right into the masticator space. So I don't routinely electively treat this, but sometimes with patients with gross disease, you will see that they will have significant trismus because the tumor is actually going right into the pterygoid musculature and then can actually have masticator space involvement in these patients. This is another setting. When I'm doing V3s, I love IV contrast. Dr. Martinez, before you even ask that question, I'll say, because it's so helpful to be able to see the musculature, to be able to see that peripharyngeal fat where that nerve is going to go through. So it becomes really, really helpful for you to contour here. Again, just showing you, here's that foramina. This is the area medial to the lateral pterygoid muscle, right where that nerve is traveling through. And then it's going to go into foramen ovale. Ovale probably is the easiest cranial foramina for us to detect. Looks like a tear. So you can see it's right here going through ovale. And then again, remember, V3 does not go into the cavernous sinus. It goes right from foramen ovale into Meckel's cave. So again, it becomes really important to make sure that you're contouring Meckel's cave and you end up. So I will say, as I think about these patients, I'm not contouring slice by slice. The first thing I do is I contour all the things, the foramina. So I'll contour the mental foramen. I'll contour the mandibular foramen. I'll contour the peripharyngeal fat right lateral, that is medial to the lateral pterygoid musculature. I'll contour foramen ovale. I'll contour Meckel's cave, and then it's literally connect the dots. Be generous. At least use if you're using a brush, use a thickness of at least 1 centimeter, sometimes even larger. Don't just draw a very small line. You want to make sure that you're covering. Remember, the nerves have lots of unnamed small branches. So it's not just covering the nerve pathway, but some of the smaller branches that are going to be right next to the nerve for these patients. This is, again, just showing you that example. So again, a lip tumor, mental foramen, mandibular foramen. You can see contouring this very, very generously, covering all of that mandible here. And then here's the mandibular foramen. You can see, again, contouring very generously, covering all of that mandible here. And then here is foramen ovale. And so, putting a nice margin around foramen ovale. And now this is a patient of mine, again, kind of showing you, again, the postoperative setting. So you can see contouring this very generously. You can see contouring the hardware in this case. And again, in the postoperative setting, it's always very challenging because all of those bony landmarks are lost. So you can see this patient's had a partial mandibulectomy. So symmetry is very, very helpful. Here's the mandibular notch. I drew something where I think it would be, and I covered it right here for this patient. This is now contouring the path as it goes medial to that lateral pterygoid musculature. This is now contouring right at the level of the foramen ovale. And you can see what this looks like on a sagittal view. Last is facial nerve. Facial nerve, as you know, has many branches. I think, it's very easy for us to contour up to zone 1 of facial nerve because we're very used to contouring the parotid gland and we know where the stylomastoid foramen is. The hardest part for facial nerve is really contouring zone 2. It's contouring the mastoid segment of the nerve for those patients. So this is, again, just showing you a tumor bed for somebody with a parotid malignancy. Again, you're going to now think about the landmarks that you're going to mark are the stylomastoid foramen, the petrous portion of the temporal bone, and then the internal acoustic meatus as you come inside. So stylomastoid foramen right here, as you can see, mastoid, styloid process, the foramen is right between the two of them. So you can contour right there, and this is just showing you some of those slices. And then this is the hardest part, I think, is contouring the petrous temporal bone. And here you have to be very, very generous. So once you kind of come in from the stylomastoid foramen, really you're going to contour the anterior half of the mastoid bone right here, the mastoid segment right here, because the nerve just traverses in and out right through here. There are lots of turns in here. So again, you can certainly contour this. So what's the cost of contouring this? When you treat a patient, they're going to say they get conduction deficits, so they're going to get hearing issues for these patients. But this is always a delicate decision of how far you're going to trace the facial nerve. But if you have to treat the facial nerve, you have to consent the patient for long-term decrease in hearing. They don't lose the hearing completely, but they will definitely over time have significant decrease in their conductive hearing for these patients. This is showing you the second segment, and then you end right here at the internal acoustic meatus. So again, you can see, this is the cochlea, and this is the canal right here and the internal acoustic meatus for these patients. So this I also find challenging because, you're going to, if I didn't put a poll right here, but I would ask you the same question. If you're going to treat this 50-54 gray, what is the dose that is to the cochlea? And again, it's prescription dose. So you're not going to spare the cochlea here in these patients if you make the decision to treat these. There are communications that you have to worry about. There's a very special communication between the facial nerve and V3. And so this is the connection to the auriculotemporal nerve. And so particularly in patients when I have an adenoid cystic patient where I'm going to, of the parotid gland, and I'm going to treat cranial nerve 7, you have to make sure that you cover the auriculotemporal nerve to foramen ovale. And we'll show you that in just a minute. Again, this is just some anatomy. Let's go here. So again, this is a patient where you're treating the parotid bed. As you can see, very generously, all the parotid bed is in here. This is where that nerve would be. This is a question I know we love asking medical students. What divides the superficial lobe of the parotid and the deep lobe of the parotid? And it's the facial nerve. So right there, again, not visible on any imaging. Okay, so this is completely something that you have to be in the OR to be able to see it. This is showing you kind of the contours as you're going through the middle segment of the nerve. And I wanted to show you so you can see, your stylomastoid foramen would be here. I usually very, very generously am going to contour, at least the anterior 1/3, if not the anterior 1/2 of the mastoid segment. So you don't have to get very cute here, but this is that petrous portion of the temporal bone. You have to generously cover this to cover the nerve. And this is that connection between 7 and 3. So this is foramen ovale. This is you coming in and contouring the petrous segment of the nerve. And you're basically making this connection between the two of them. This is where the auriculotemporal nerve goes through. So this is an easy thing to treat, right? There's not a lot of toxicity there if you're going to go anteriorly and cover foramen ovale. So, this is an easy decision to make to add the connection for these patients. This is just showing you a representative case of mine. Somebody, again, you can see with a parotid tumor, treating the parotid bed. You can see these contours here. And you can see how in the postoperative setting, everything is altered because in my patient, they actually went in and drilled. They went all the way to zone 2. They actually drilled the petrous, the portion of the temporal bone here. So you can see, you can't see normal mastoid cells because they've been drilled through. So you can get some idea of these contours here. And then I make the decision here to cover and connect that connection from cranial nerve 7 to V3. And so covering ovale in this patient. So you can see this is what these contours look like. Gonna end by just talking about, this is a patient of mine. It's one of the first patients I think I ever treated with protons here. But this is a patient, wife of a former chair of neurology. So I want you to appreciate how difficult this can be, who came in with a 7-year history of progressive right-sided facial numbness. She then ultimately had facial paralysis and had multiple misdiagnoses over that time. Again, herpetic neuralgia, monoglomerular gammopathy of unknown significance, Bell's palsy. And this lasted for 7 years until she had radiographic findings. And these were the radiographic findings that she came in. So now you can see this tumor is intracranially, you can see along the superior orbital fissure, going into the cavernous sinus, going into Meckel's cave, going into the sphenoid sinus and the sella, and then going into the brainstem. And so here's T1 post-contrast MRI. Here's T2 MRI sequences here. So you can see very, very extensive disease. And she ultimately had a biopsy 7 years later. This was just metastatic cutaneous squamous cell carcinoma in this patient. And so you can see in this patient, I ordered a PET scan. PET is not always very revealing. You can see a very small segment actually was hypermetabolic here. But given that she had visible disease into the pons, I made the decision to treat the brainstem in this patient. So you can see these are my volumes in this patient, very, very generous. As I say, I always go by the principles of symmetry. So when I can't see anything on the side I need to treat, I'll contour the foramina on the opposite side just to make sure that I am at the right level and covering what I need to cover. So this is what I treated. This is what I treated with protons. And this lady came in with exquisite facial pain. I mean, she was on the highest doses of gabapentin. She was on opioids. She was on tricyclic antidepressants. You name it. It was like seeing somebody with, just trigeminal neuralgia for this patient. She had exquisite relief of her pain. And this is before routine use of immunotherapy. So this patient didn't get immunotherapy. But I want you to highlight the challenge of what happens with untreated PNI. So this is that same woman 6 months later after finishing her radiation, and you can see that she had a drop metastasis in her cord and came in with frank cord compression, and then we radiated this. And she ultimately died really of just florid leptomeningeal disease along her spine. And so this is why these decisions are so important for us to make sure that we're treating this at the earliest possible scenario and not waiting until you see radiographic PNI, because this is what happens, and this is the natural history for these patients. I wonder now that in the area of immunotherapy, maybe this would not happen. So I really am a big believer in immunotherapy for cutaneous malignancies. So here's poll 3.
So poll 3. Okay, I think everyone is seeing it right now. If you don't see it, you can add your answer on the chat. So for which of the following histologies is it particularly important to cover the path of the anatomic nerve to the skull base foramina? Uy. Okay, I have my answer. Okay, I think the answers are coming up. I'm gonna wait until half of the participants have answered. Otherwise, we're seeing lots of A answers on the chat. Okay, we're almost half of our participants have answered, Dr. Parag. So here are the answers.
So you're all listening. So adenoid cystic carcinomas, we've talked about this a lot. Please, I can't tell you enough of this. Never believe the path report, even if it says there was no PNI in an adenoid cystic carcinoma case. It is pathognomonic that those patients have PNI, and you should always, always, always at least cover the zone 1 for these patients. And I will tell you that in my practice, more and more, I actually cover all the way to zone 2 for these patients electively. And the reason for that is, as we all know, adenoid cystic carcinoma patients live forever. And they will fail along the nerve paths as they live forever. And so it's not just the local control for 5 years, it's the local control that you want to make sure that they have at 15 years, 20 years post-treatment. Now, unfortunately for adenoid cystic carcinomas, if they live long enough, I will say virtually everybody ultimately develops distant metastases in the lung. So just something to be mindful of as you take care of these patients, over a couple of decades. but generally even their lung metastases are very, very indolent. So local control and perineural control is paramount in these patients. For BCC, again, for the vast majority of patients, you don't need to treat it. But if you had a sclerosing or an infiltrating BCC, please treat for those patients. And again, Merkel cell melanoma, we have lots of other issues for those patients. But thankfully, PNI is not an issue except for one particular type of melanoma. So I'm actually going to ask a question, and maybe people can put in chat. Which subtype of melanoma do you think about perineural invasion?
So for the melanoma, actually someone at the beginning sent desmoplastic melanoma.
Very good.
Okay.
Very good. That's
Okay,
exactly right.
Maffer también. Maffer also sent desmoplastic. So it was
Perfect. Perfect. So, for desmoplastic melanomas, as you know, we have kind of gone out of favor, at least for postoperative local radiation in melanoma, right? Most patients now go to immunotherapy. It's very rare that we see these patients for postoperative radiation. But the one group of patients, again, I will say, pathognomonic that they have PNI is desmoplastic melanoma. And the interesting thing about desmoplastic melanoma is that unlike other cutaneous melanomas, they have a much lower predilection for either regional metastases or distant metastases. So their primary pattern of failure is perineural. And so these patients, local adjuvant radiation is really, really important. And so please see those patients and treat those patients.
Parag,
Dr. Martinez, yeah.
I have a question about if you make any difference between the focal or extensive perineural invasion on your CTV coverage.
Great question. So if there's focal PNI and I don't see any other risk, so say it's a skin cancer focal PNI, no other risk factors, I may just treat that with the resection bed with generous margin with electrons. But for that same skin cancer patient, if I see extensive PNI, then I am going to electively chase the nerve pathway to zone 1. Now, to your point, if somebody has extensive PNI, are my CTVs slightly bigger? Absolutely, because I worry a lot more about the branches, the unnamed branches along the skin. So my skin margin is going to be very generous for somebody with extensive PNI because I really want to cover the resection bed with as wide a margin I can get. So generally on the order of 2 to 3 centimeters for those patients on the skin.
Great, thank you, Parag.
So we're almost at the end of the talk. I'm gonna end, and then I'm really happy to take some questions. So really, as I talked about, Maria, is there a way for you to stop the poll, or maybe it's just my screen?
Do you want me
Here.
to?
No, it's okay. Let me do that. I'm gonna again stop my screen share, and then
Okay.
I'll come right back. Sorry.
Okay.
Okay, perfect. Oh, it keeps coming back. Oh, there we go. I moved it. Perfect. Sorry. There we go. So as we conclude about these patients, so what I would say, early stage non-melanoma skin cancers, just treating the tumor but with generous margins. The exceptions, as we talked about, the high-risk basal cell that is infiltrating or sclerosing, extensive PNI, as Dr. Martinez just talked about, any named nerve, certainly. And then the fourth thing really is immunosuppression. So again, solid organ transplant patients, so kidney transplant, liver transplant, heart transplant patients, I will always treat the perineural pathway for these patients because their skin cancers are just so aggressive. Patients who have underlying CLL, as we know, CLL increases the risk of skin cancer 6-fold, and these tend to be very aggressive. Patients who are on CLL therapies like ibrutinib, I'll consider it for those patients as well. For mucosal head and neck malignancies, if there's just focal PNI, I'm going to cover the tumor bed with generous margins. If there's extensive PNI or named nerve, I'm going to cover the nerve pathways for these patients. Obviously, nasopharynx patients, by definition, we're always covering nerve pathways, even for our T1 patients. So that's definitely the exception. And then adenoid cystic carcinomas, as I said, I always cover zone 3. I always cover zone 1, but generally even zone 2 in most of these patients. And then certainly covering the connections between, really V3 and 7, V2 and 7, important for us to cover those if at all you're worried about risk for these patients. And then finally, as I said, your clinical exam and clinical history is so important. So really, if you know a patient's had prior skin cancer and coming in with numbness or facial weakness, honestly, it is skin cancer until proven otherwise. Ordering the appropriate imaging, CT and MRI, and even if you don't see anything, not ignoring those patients, and then treating these cranial nerves, as I said, at least when you have these clinical PNI where you have no imaging findings, you should at least treat V1 and V2 to cavernous sinus and Meckel's cave for V1, V2, V3, and to the internal auditory canal for cranial nerve 7. So this is the best time to be aggressive for these patients to make sure that we are preempting a bigger problem downstream for these patients. And then for radiographic PNI, these are the worst actors and the worst players. If they have disease only involving zone 1, these are curable. These are patients that you should discuss with your surgeon because surgery, upfront surgery followed by postoperative radiation probably gives them the best chance of cure. Zone 2, as I mentioned, is resectable with great morbidity and great skill. So this is a case-by-case discussion, how anatomically feasible this is, what kind of deficits the patient's going to be left with, and then really partnering with the surgeon whether you're going to do surgery or not. Certainly, you're going to treat these patients with radiation, and about half of these patients will be curable. Zone 3, the cure rates are very, very low. You can see an overall survival, just the overall survival is low. They're generally fatal. And generally, the big issue for these patients is just distant disease, so just disease extending into the brainstem or drop metastases. For any patients with radiographic PNI, I'm always going to cover zone 1 and zone 2. And if there's any zone 3 involvement, I'm going to cover the brainstem. So I know we get nervous. Again, we try to spare the brainstem for most head and neck cancer patients. But remember, we treat brainstem gliomas all the time. And so if you have disease in the brainstem, you have to treat the entire brainstem at least to about 50 gray for these patients.